All right. Well, it would help if I turned the screen on, wouldn't it? All right, we finished. We were talking about the different drug targets, okay? And we basically made it through nucleic acid synthesis. We had one target left, and that one target left is metabolic pathways. More light here today than we normally do. Not bad.
Movie time.
Oh, come on. All right, still not coming up.
What'd you do?
I don't know.
It's okay, you can turn it off. We can take it out.
There we go.
There you go.
All right. So the last pathway we have to talk about, the last potential drug target, is going to be metabolic pathways, and specifically we are discussing the folic acid synthesis pathway, okay? We have talked about this one before. Humans do not have the ability to make their own folic acid. Guess what? Bacteria do. So this particular target is a really good target. This is a really good set of drugs that are selectively toxic. In other words, they target the microbe and they leave human cells alone because we do not have any of the enzymes involved in making our own folic acid. So in this particular metabolic pathway, if you ever take a sulfa-based drug, those sulfa drugs are targeting an enzyme in what's known as the PABA pathway. If you take another drug in this target known as trimethoprim, it targets an enzyme farther down. These particular drugs, however, work really specifically. There are no targets, or there are no targets in human cells that these will attach to, okay? So these work really well to cause death of a microbial cell. However, there's a caveat that comes with taking one of these drugs. Can you think of a time when you would not want to take a folic acid targeting drug? When you're pregnant.
Neural CP tox.
Exactly. So when you are pregnant, you are taking extra folic acid to prevent neural tube defects. You have lots of folic acid going through your system, at least you should, because you should be on a good prenatal vitamin. When an organism cannot make its own folic acid, do you think it rolls over and dies? No. No. What do you think it's going to try and do instead? Find another source, which is going to be your body. Okay? If the organism is in your body and it's causing infection, and you take a drug that's targeting folic acid synthesis, it's like I can't make my own folic acid, but all around me there's all this extra folic acid. It literally takes it from you and it utilizes it. So in that scenario, those organisms are not going to be dying off quickly. You're taking the drug and it's not going to go through its entire course well to kill off that particular organism, and it's scavenging the folic acid that you need. Okay, so these drugs work really well. Guys, you can take these drugs without fear of having any issues with this, okay? Ladies, if you're pregnant, this is a drug that you don't want to be on. You want to say, okay, I get it. It's a good target, but not for me, not while I'm pregnant, not while or if you're on a prenatal vitamin or on extra folic acid, you don't want to take a drug in this category.
Folic acid with combination of other molecules and other drugs can like decrease stress, anxiety. I've seen like vitamins that have like a lot of folic acid, like a lot of glutamate, a lot of like calcium. That is just like one vitamin specific target to like anxiety and stress.
I mean, it's good for growth and development. I have no idea if folic acid is involved in reducing stress or anything like that. I could look that up.
I was just
She
asking
brings up a
because
good point.
I was at GNC the other day and I saw like a vitamin.
Exactly.
I saw like a vitamin that was like stress.
None of those are usually like FDA approved. They're
Yeah.
just like speculative.
Don't get vitamins for stress.
No,
Go
no,
do
but I can
acupuncture
actually- I saw
or
the back and I
essential
saw it
oils
was, like,
instead
a
if you
lot
want
of
something
folic
else that's
Or
not
Xanax.
or a Xanax.
Yeah.
Wellbutrin
or Adderall.
What is that?
Wellbutrin.
Oh, really?
No, it is not.
I don't know why.
I can't believe we're on the same one. That's hilarious.
I make
There's so
natural
many.
Adderall.
I have one in here somewhere. You combine it with the lavender and it's liquid Xanax.
Yeah.
But it's an essential oil. You smell like
Do you use
lavender when
doTERRA? You
Yeah.
get a little behind the ears, and then you
Yeah.
drink your vodka.
Right, exactly. I put it on my
Which is a
kids
def-
before they went to school this morning. I was
I
like,
put
here are your
On Guard.
focus blends,
Yeah,
Which is
the
the
depressant,
on guard
which
stuff,
makes you more anxious.
not the vodka.
Vodka's a
I
depressant.
need it. I think it's so funny. Just dab a little lavender and then just swallow your Ativan. Works wonders.
All right, so these drugs are really, these antibiotics are really good stuff, okay? Sorry, I had one more target, okay, and that is the cell membrane. Bacteria have a cell membrane, we have a plasma membrane. The structure is practically identical, okay? So when it comes to drugs that target the cell membrane, there's only one of these, it's polymyxin B, and this one is topical only, it's kept in first aid ointments. This one is really good in terms of binding to the membrane of gram-negative cells, but it basically causes cells to lyse open. Keep in mind, this is not one you want inside. This is not an ingesting thing only. Remember, we're not eating Neosporin, okay? Because what's in there, those particular drugs, the targets really cross over. They target human cells as well. They have a lot of other side effects. Their uses are limited. So we had we had a list of targets. We had cell wall, we had cell membrane, working our way in. We had folic acid synthesis, nucleic acid synthesis, and ribosome structure, protein synthesis. Those that are unique to bacteria, that we can get some sort of unique characteristic out, those are going to work much better in terms of being selectively toxic for the microbe and not targeting your cells along with it. So cell wall synthesis targeting drugs work really well because we do not have a cell wall, we do not have peptidoglycan. The protein targeting drugs work really well because our ribosomes are different than bacterial ribosomes. The nucleic acid synthesis targeting drugs work okay. They work on a coiling procedure that's more prone to happen in bacteria and less prone to happen in human cells. And then you have those folic acid targets, which are really good because we don't have the ability to make folic acid. Targeting the cell membrane is one of those. We have the drugs for it, but they're not great because there's a lot of toxicity with human cells because we have a plasma membrane and the structure is very similar. So not all antibiotics are created equal. Not all antibiotics are going to be equal in terms of less side effects and equal targeting for the drug. There's always going to be pros and cons that happen with all of this. Remember, the goal is to kill whatever it is that's causing your infection and to leave your cells alone. So the target is always the bacterial cell. When you get an infection, the best thing to do is to figure out what's causing that infection, okay? Now, if you have a life-threatening septic infection and they say, we have to put you on antibiotics now, and we're going to figure out what you've got, but it's going to take us 48 hours, but we want to try and put you on something broad spectrum now to kill it off, do it. That's, life-threatening issues are a different scenario. If you have the ability to figure out what is causing your infection and to give a specific drug against that, that's always going to be better. And that's going to be better because you're not going to be destroying your normal flora, and it's going to be less likely to have, they can put you on a drug that has fewer side effects and is more specific for the microbe, okay? So if you can wait 48 hours to determine what that organism is, do it, okay? Even if you can't, they will put you on broad spectrum to start with, and they will figure out what it is you've got, and they will determine if they can move you to a more narrow spectrum drug or not. At one point, they would basically throw you on something broad spectrum and tell you, if you don't feel good in a couple of days, call me and we'll put you on something else. And that was always the motive, like, just take this, call me if you don't think that's working, okay? We now understand that that's a really terrible idea because it's promoting resistance in your body, it's promoting mutations in your body, and having all of these antibiotics is not doing your system any good, okay? We want you to take something that's targeted for that infection specifically whenever possible. So what we do now is called a drug susceptibility test. This is typically going to take 24 to 48 hours, typically minimum 48 hours, okay? If they have some idea first or they can get a pure culture quickly, you might get an answer faster. Half the time, they need to determine which organism is causing your infection. They need to get a pure culture from that. So just like what we did in exercise 6, where we streaked it out and then we did a subculture from that plate. then it's taking it and doing one of these susceptibility tests. So what you're looking at, there's two different ways to do a susceptibility test. This is known as the Kirby-Bauer test. What you do here is you streak the organism all across the plate. You create a lawn of organisms. So everything that you're seeing in this like creamy yellow color is all growth of the organism. Then what you do is you put on these tiny little filter paper discs that have been soaked in a set concentration of an antibiotic. And you give it 24 hours to grow. And then you come in and you measure what's known as the zone of inhibition. And the zone of inhibition is the diameter from one side of the clear zone through your filter paper disc to the other side of the clear zone. And you're looking for a set amount. In general, the bigger the diameter, the better it works. But every one of these antibiotics has a minimum size you have to achieve. So for example, this antibiotic here is doing nothing to kill off this organism. Okay? The rest of these antibiotics are working. The question is, to what extent are they working? This one's not working very well. This one, because this pattern is a little bit uneven, we're seeing some resistance that's happening with this. This guy up here has got a really big, really nice, round, clear zone. So that one's working really well. So what you would do is you would identify, okay, we put 10 different antibiotics here. We've got 6 different ones that have a zone that tells us those antibiotics work. Let's look up these 6 different antibiotics. Let's say pros and cons versus all of these, and figure out the best antibiotic to give that particular patient. Okay, well, 3 of these are broad spectrum, so let's throw those out. We left with 3. We have a kid. This infection is in a child, so this one here is a tetracycline-based drug. We're going to throw that one out because that can cause tooth lines across the teeth later. We're left with these 2 antibiotics. Which one is more narrow spectrum, and which one's got the fewer side effects? Okay, so it's a kind of you see which ones work, and then you start throwing out the ones you don't want to give until you're left with one that's going to be optimal for that particular patient. Another way of doing it, so that the Kirby-Bauer test has a set concentration. A better way of performing that test, but you can test fewer antibiotics in one plate, is to do the E-test. So the E-test is interesting because this guy actually has a gradient of the antibiotic. So this guy has more antibiotics towards this black line here. This is the maximum concentration. And then it's got less and less and less antibiotic as you go down. So what happens in an E-test is you get more of a teardrop effect. And the teardrop is going to be widest at that maximum concentration. And when the antibiotic no longer works, it hits that minimum inhibitory concentration, that's where the line then starts to cross in. And we know from this point down the antibiotic doesn't work anymore. This allows you to say, okay, I know this antibiotic has to work for this patient. How much of that antibiotic do you give? I mentioned BB Bach, and you were like, sounds good. I had to go get it. I love it. Okay, so this is really nice because that helps with dosing as well. That helps you say, okay, wait a minute, which antibiotic works? But then I don't want to give this patient a massive dose of that antibiotic. How little of the antibiotic can I give and still have it be effective? Okay? So if they tell you we're going to do a susceptibility test or we're trying to figure out what antibiotic works, they're doing this sort of test. Okay? So it's all about figuring out what the best drug is, what the best drug is not. But understand you have a choice. If you don't like something, you should tell them you don't like it. Okay? My kid was at Children's over between Christmas and New Year's. They put him on a drug. It was a disaster. They sent us home. I was like, okay. She said, well, we're doing a susceptibility test. I said, fine. They called me the next day, and they said, we're switching his antibiotic. I'm calling this one in instead. And I said, wait a minute. Let me look it up. What is it? They literally put him on another broad-spectrum antibiotic with the same exact target. And I said, no, I'm not going to pick it up. And she was like, listen, I'm a specialist. And I was like, listen, I'm his mom, and I'm not giving this antibiotic. I was like, I don't care. You can call. And she called it in anyway. I said, I'm not picking it up. You've got 2 targets that are exactly the same. I've already spent $50 on antibiotics. And you're not changing anything. It's still broad spectrum. You haven't identified a narrow spectrum drug. And she was like, well, I get that, but this one is a little bit better of a target. And I was like, forget it. I'm not doing this. I'm done. And did I know she labeled here's this antibiotic, here's the brand name. I was like, forget this. I Googled it. I was on the computer while I was on the phone looking it up because I was like, I'm never going to know all of these antibiotics. And I made a decision then and there, okay? It's all about understanding what you're going to give and what works best. You have the ability as the patient to say, I'm not taking that, or find me something else if you don't like what they come back with.
I feel like they're really weird because I do that a lot just based on like what I've taken, what's
Right,
worked.
right,
And I feel like they get so weird because they're like self-diagnosing kind of. Like,
right. Well, she was like, listen, I'm the infectious disease doctor. And I was like, listen, I don't really care. And I had said, listen, I have a degree in this. Like, you're not talking to your parent who doesn't know anything. And I was like, and I said to her, I said, if you can give me a conclusive answer, logically thought out as to why I should give this antibiotic instead of the other one, I am more than willing to switch. And she had no answer. She said, we did the susceptibility test, and this is one that came back. And I was like, but you're not telling me why. You still can't explain to me why, and you can't explain to me why this one is better than that one. So if you're not going to be able to reason out your test results, like that doesn't help me at all.
Exam.
What's that?
Did you fail your exam?
Yes, I was like, ew, okay, so she didn't call me back at all, but it's kind of like we're going to get a lot into this immunology, taking drugs and other stuff. You get better care when you become more informed. So I know you hate this class. You're like, microbiology sucks, okay? But the more you know, or the more you're willing to look up, the better off you are. Bottom line. And the more you can say, just explain that to me. Just explain it to me. It says a lot. Half the time the nurses know more than the doctors do. The doctors are like, well, I understand it. But it's the nurses that actually have their crap together and can explain how it's all working and what the better answer
Are we
is.
doing
Okay?
these two tests in
The one time we were in there, a friend of mine who teaches physiology was also there. And they sent in a medical student, and she ripped him. And I was like, and then I had some questions they couldn't answer, and I said, okay, look, you're going to go back out in the hallway, and you're going to talk to your attending, and you're going to look a few things up, and then you can come back. And he was like, they just, and I said, it's fine. Just, we had some questions, and you couldn't answer it, and it, like, this is how this works.
Teachers are
And when
really
it's dealing with your kid, it takes on a whole nother level. But it's all about being informed, and it's all about understanding what you have the rights to and what you don't have the rights to. So doing a susceptibility test, and you can see kind of an actual application here, can become a really important process, especially if you've been on tons of antibiotics and you're really worried about resistance, or you're like, I've been on 5 of those and that one causes nasty side effects and I hated that one and I don't want to take this one. I would rather take this or this instead. They should be willing to work with you when it comes to that, if it's going to work. And if it's not going to work, they should be able to explain that to you.
The last time I went, I told her that I was like resistant to Bactrim because it hadn't worked
Yeah.
for her, and she argued with me, was like, do you have a test to prove it? And I was like, why would you give me something that hasn't worked it previously?
Right.
I just,
Right.
I don't know.
Like
It
literally,
bothered me.
you have a whole list of antibiotics.
I know.
You can find something else that
know.
works if I don't
Why
want to
would you
take that
even,
one.
Like,
Yes.
try? Because then I'm taking this for no reason. Then I have to come
Right,
back in.
right. They just assume you don't know anything,
Yeah.
or that you haven't paid attention to what's worked on. Right. Where this is entirely leading is this concept of drug resistance, okay? So you only want to take an antibiotic when it's necessary. So, you get an ear infection, chances are take the antibiotics, okay? You get a urinary tract infection, take the antibiotics. Can lead to a bladder, it can go from the bladder to the kidneys and then become a septic infection. You have a cold, you're not taking antibiotics. So understand when you need the antibiotic and when you don't. And you want to take the most narrow spectrum drug possible. So what's becoming resistant? When they talk about resistance, the bacteria that are in your body that are causing whatever it is you've got, those are the ones that are becoming resistant. And what that means is that they actually start to tolerate, and they don't care about drugs that would normally kill them off. So it's like, listen, I know you would normally destroy me, but you have no effect on me anymore. I'm stronger, I'm Superman now, and everything is okay. All right? So then it no longer works. This can be something that they acquire over time. This could be organisms that are naturally resistant. So another reason that the susceptibility test becomes really important is because you could have an organism that just naturally doesn't work. Those 5 different antibiotics just naturally don't kill it, Okay, so resistance comes in all kinds of different forms. If it develops resistance, it's typically because they either get a spontaneous mutation or because those plasmids, they participate in conjugation, and through that conjugation process, they transfer in new genes. Okay? There are 5 different mechanisms of resistance. You want to understand the 5 different mechanisms. Okay? How many did we do?
No, oops.
So the drug resistance, you're wanting us to know, like the drug inactivation, decreased permeability, that stuff? Those are the 5?
Exam is on Monday. Okay? There may be a question or 2 that deals with this.
Maybe.
All right? Maybe.
Just 1 or 2?
Yes. I'm not going to give you all the questions on this. But you want to understand the mechanisms and how they work. Okay? So there's 5 different ways an organism can be resistant. So the first one is drug inactivation. Basically, the organism gets an enzyme, and that enzyme cuts apart the drug so that the drug just is inactive and doesn't work anymore. So the example given here is penicillin ACE. Penicillin ACE kind of sounds like it's an enzyme that degrades penicillin. Okay? Literally, it cuts apart that penicillin. Everyone it sees, it just destroys, and then the penicillin does nothing. Another example is called decreased permeability. So these drugs have to get inside the cell to work. To get inside the cell, they have to bind to a receptor on the surface, and they have to be taken up inside the cell. What happens in decreased permeability is that this drug, the microbe goes, look, I'm just going to change my receptor. It alters its receptor just a little bit, so now the drug never enters the cell. Even though the drug is in your body, it doesn't get inside the bacterial cells, and it literally does nothing. Another example is called, or use of a drug pump, or activation of a drug pump. And I think of this as kind of in one ear and out the other. So even though the drug comes in, it gets pumped right back out. So it comes inside, it gets pumped out before it ever actually does anything. Okay?
Actually into the cell.
It gets, so it comes in through the normal receptor, and then it gets pumped out of the cell. Like the sump pump in your basement, okay? You have all this water that's potentially coming in to flood your basement. Your sump pump keeps pumping all of that water straight on out before it ever has a chance to flood, you hope. You hope, okay? Same thing, it's coming, even though the drug comes in, it gets sent right on out before it ever does anything. The next one is a change in the drug's binding site. So for example, this drug is targeting the ribosome structure. Remember your ribosome? 2 different subunits. It sits down on that transcript, and as the transcript comes through, it makes proteins.
What?
Okay?
Say that one again, please.
Ribosome.
Yeah.
Two separate parts of the ribosome, large subunit, small subunit. Here is you're looking at your mRNA transcript. The way the ribosome works is it clamps onto the transcript, and as it moves down, it builds the protein, okay? So for a drug, for example, that targets protein synthesis, it's typically going to latch on to one of these subunits of the ribosome. So normally, you're going to have this process that happens. The drug sits here, ribosome can't attach, the cell is going to die. What can happen is this ribosome can actually change its binding site. And when it changes its binding site, the drug no longer binds on here, and now the ribosome functions as it normally would. Okay?
So this is not referring to any kind of receptor on the host cell, it's talking about the receptor on the
Right.
ribosome.
Host cells are not involved in any part of this. It's all about the microbial cell. So in this case, the drug is going to come through the receptor on the outside of the microbial cell surface. The drug gets inside the cell, but the drug can't actually bind to what its target is. So even though it's inside, it doesn't do anything. And basically it has absolutely no effect whatsoever. And the last one is to use an alternate metabolic pathway. So for example, think folic acid synthesis. If you are using a drug that takes B, you're using a drug that blocks the production of taking B to C. Anytime that this guy is shut down, the whole pathway is shut down, the organism's going to die because you're blocking an important biochemical pathway. What this guy can say is, wait a minute, I can't make this pathway work, but I can find alternate ways of making these intermediates and an alternate way of getting this end product. As long as I get there in the end, it doesn't matter the fact that it's taking a drug and the drug is here, it's finding a way to get there, okay? This is like there's the freeway is shut down on your way to school. Some of you might turn around and go home. And others would go, okay, wait a minute, I have to get to class today. So, you know, Waze is telling me I need to go this way instead, and then here, and then finally I just end up in this parking lot and I'm good to go, okay? As long as you got here, it doesn't matter the way you took, as long as you got here in the end. So all of these are finding ways around our drug targets. So for example, drugs that target the cell wall typically are inactivated through drug inactivation pathways. Drugs that are dealing with cell membrane issues are typically inactivated through a decreased permeability receptor. We change the receptor, it's not working anymore. And this can affect everything downstream, whether that's a DNA synthesis drug or a protein targeting drug as well. If we activate a drug pump, the drug comes in, the drug goes right back out, it never works. If what you're taking is something like a protein synthesis targeting drug, changing a binding site can be really important. If you're taking a folic acid targeting drug and it's capable of finding an alternate way around that pathway, it can be really important. So all of these are ways of the microbe saying, listen, I know you're taking this drug and I know the drug is trying to kill me, but I'm going to find a way around it so that even though the drug is here, the drug doesn't affect me anymore. So resistance is specifically with the microbial cell, and it's that microbial cell's way of fighting off whatever that drug is.
How do people find out which exactly your body is doing?
So you would have to isolate the microbial cell, because it's all about the cell. You'd have to isolate that, and then you'd have to do an analysis on the cell. So that could be, typically that's going to be a biochemical pathway. That's going to be breaking it down and looking at its genes and doing an analysis that way to figure out which one of these it's
So
doing.
if you're becoming resistant to a antibiotic, they just go through each one, right?
So-
That test, they're just going to figure out, okay, we might be doing this one, we'll try a different one.
Right. So if you are, so if the, when they say it's resistant, it's the microbial cell that's resistant, it's not your body.
Right.
And what they're saying is basically they've looked at it and that drug is not working against that organism. And we know that drug targets the cell wall, or we know that drug targets DNA synthesis. They will typically say, we think there's a resistance against this. We're going to try a drug that has a completely different target and see what happens. But if they've done that susceptibility test, in that susceptibility test, you're going to have drugs that have all kinds of different targets, so that should automatically take care of that. If they do the susceptibility test, you should be worried less about resistance if they can find you a more narrow spectrum drug. It should identify resistance and it should weed all of that out. If they never do the susceptibility test, that's when you have issues. Keep in mind, every time you take an antibiotic, you are promoting resistance in your body. Antibiotics are killing bacteria. They don't say, wait a minute, you've got a urinary tract infection. I'm only killing the bacteria in your bladder. They cannot do that. Instead, they wipe out the bacteria everywhere in your body that that drug comes in contact with. So every time you take an antibiotic, you are killing off your normal flora. That's more true when you're taking a broad spectrum antibiotic. It's less true the more narrow spectrum drug you're taking. So that's why you always want to take a narrow spectrum drug if possible, because it's going to help protect against killing off all your normal flora. What happens? Think of this petri dish as being your gut, okay? Originally in your gut you have all of these different organisms, but maybe you have a couple of guys that are drug resistant. These drug-resistant organisms are kept in check by all of the not drug-resistant ones around them. They're competing for nutrients, they're competing for space. So when everybody is here, this guy is really not causing any problems. But you take an antibiotic, and that antibiotic starts wiping out these normal flora. Over time, every one of those susceptible organisms dies off. And what you're left with, the longer you take that antibiotic, is an area that's now devoid of lots of good normal flora. And what you have now are all of those resistant guys and lots of open space for them to keep colonizing. So you go off the antibiotic, and these guys now start to colonize. Now what you're left with is a stomach full of resistant organisms and very few ones that are susceptible in between, okay? Now in general, if you're taking a generic course of an antibiotic, 10 days, 7 days, something like that, you're gonna promote some of this, you're not gonna get a ton of it. The longer you are on antibiotics and the more frequently you have to take them, this is what you start to end up with. It leaves you susceptible to all kinds of other infections. So patients who end up on antibiotics for large courses of time typically end up with all kinds of other infections that then start to pop up because you're depleting all of your normal flora. This is when you can then start talking about taking a probiotic or taking good normal flora to try and replenish that particular environment. Okay? Where are we seeing resistance? Okay? There's lots of enterococci that are now becoming resistant. So lots of organisms that are normal flora in your intestines are becoming resistant, and they're a common cause of nosocomial infections. What are nosocomial infections?
Hospital-acquired infections.
Hospital-acquired infections. The biggest way we see this, catheters, okay? So in the event the area is not properly prepped and clean, okay, you can easily end up with intestinal organisms that get introduced via a catheter in the hospital setting. The patient doesn't know they've gotten a UTI because they have a tube stuck up there, okay? They can't feel much of that anyway. And you can see that that's a common cause. If they end up with some sort of intestinal perforation or other things, those also leads to nosocomial infections. But typically, the biggest way you see that is with a catheter insertion. So a lot of our intestinal flora are becoming resistant. You think of something like C. diff, okay? Clostridium difficile makes an endospore, okay? Is resistant, has an intrinsic level of resistance all on its own. People who have C. diff take antibiotics over and over and over again. And it basically causes their good normal flora populations to deplete, and what they're left with is a whole bunch of resistant cells. It becomes really hard to get rid of C. diff in a patient, which is why they then start talking about things like fecal transplants and stuff like that, okay?
Aren't they doing that in cows now?
What?
Fecal transplants.
I have no idea.
I was
Why would they
reading-
do a fecal transplant with
I don't know, I
cows?
was reading something. The
You
other
send
day.
me that. Find it. Send it to me.
Okay.
I'd love to see. I'm curious now. It'd be fun.
Maybe they're just practicing.
Maybe there's practice.
Who knows?
Keep in mind we talked about vancomycin. It targets the cell wall. It's a really good drug, but it's one of those that works with a lot of side effects, highly toxic. But it's a common one, so patients who end up with nosocomial infections due to enterococci, normally by the time they find it, you're septic. In other words, that bacteria is all in your bloodstream and moving everywhere. Vancomycin is one of those that they immediately put you on because it's got to be delivered via IV. And it's a really good drug at getting rid of these organisms quickly. Now that we're seeing a lot of resistance to vancomycin, those patients are having fewer and fewer options in terms of what do we do to treat those infections. Mycobacterium tuberculosis is another one of those. It's multi-drug resistant. If you are a TB patient, you are on a multi-drug therapy. They're giving you drugs that have multiple targets. Remember that organism is acid fast. It's a 6-month antibiotic protocol to try and get rid of this organism, okay? It's no laughing matter, and we see a lot of resistance. So you've got to take them the same time every day repeatedly. In places in this country where TB is really rampant, kind of inner city, low income, people living in close proximity to one another, lots of people living in the same apartments, they're more likely to transmit TB. There are actually government programs that will give you free medicine to make sure that you're taking the drugs to try and get that infection under control, because what they don't want is some massive epidemic and massive outbreak of TB. How those programs work, though, they actually deliver your drugs every day. They must physically watch you take the drugs because those people are more likely to not take the drugs and go sell them for other recreational drugs. but they have to watch you take them. They want to make sure that you're taking them the same time every day as appropriately, so that you're properly treating that infection. It's kind of like if we're going to give you the drugs, we want to make sure that you're actually taking them in the right way to get that infection under control. But it's a serious issue because of that organism and how it works. The last one is one you've heard of, and that's staph. Okay. Staphylococcus aureus is a common cause of nosocomial infections. It's a common cause of infections in lots of different scenarios. Wrestlers are commonly getting staph infections. Okay. Most people in nursing homes or in elderly people in nursing homes, rehab care facilities, staph aureus is everywhere, and typically it's got some level of resistance to it. Most healthy adults who get it aren't going to have too many problems. But if you are immunocompromised or something like that, you can easily have some sort of issue that pops up with this. Until recently, so if it's MRSA, so what we were doing was we were treating it with methicillin. So now we're seeing a lot of these are resistant. So MRSA is methicillin resistant staph aureus, okay? Lots of strains are still susceptible to vancomycin, so that's a common antibiotic that's being used to treat it. But now we actually have what's known as Visa. So it's vancomycin intermediate staph aureus, and the staph aureus is starting to not respond to that one as well. As we get limited in terms of the antibiotics that are treating staph, they're moving to other alternatives. So staph infections that are on the skin, what they're starting to do now is basically like a bleach bath. It's 10% bleach solution, it's sponging it on, letting it sit, and rinsing it off, and doing that multiple times a day if where that infection is on the surface. It's looking at other types of homeopathic methods, essential oils and other things to try and get these types of infections under control, because their antibiotics are really not working anymore.
We do chlorhexidine wipes in our hospital.
Yeah.
Like every 4 hours.
Yeah.
We have like some kids that are on contact for RGNR. The gram negative.
Right?
Isn't that crazy?
That's crazy.
They're like little kids
I had like this
already.
Yeah.
like, Neosporin kind of tube that I had to put in my nose, and all of my housemates in college had too.
See? Right. Probably
It's like,
more
what is that?
prophylactic. Depends on what the organism was against. And typically it's more prophylactic. You're higher likelihood. So for example, if you are a staph carrier and you've got staph aureus up your nose,
Yeah.
you're more likely to be a risk for infection with result of surgery. Like several times higher risk of getting a surgical infection if you've got staph aureus up your nose. So sometimes they've got antibiotics and creams that can basically go up there to try and eliminate the staph up your nose or other populations that you're inhaling. Yeah. Right. So what can we do to try and slow the spread and resistance that's happening? Honestly, you're relying on your physician to know what the heck they're doing. You're relying on them to give you a narrow spectrum drug when possible and to do a drug susceptibility test. They are also supposed to be talking to patients about proper use of antibiotics. In other words, if we give you this antibiotic, we need you to take it at the exact time you need to take it, and we need you to take it for the entire dose. Don't be like, I'm only taking half of this because I feel better, and I'm going to take the other half if I get this infection later because I don't want to call my doctor, okay? You need to take the entire course of the antibiotics that you're prescribed, because that's the way to make sure it's wiped out, it's in that state of prolonged decline, and that it's not going to come back later on. The more you have to keep taking antibiotics and the more they have to switch them up, the more likely you are to be building up resistance. So if you end up on antibiotics, it's up to you to follow those instructions carefully. Understand what you're doing. Understand that anytime you're misusing that, or you miss a dose, or you don't take it when you're supposed to, that's going to be leading to resistance. That's going to also be perpetuating that infection in your system.
In the hospital, like if we have a patient, they're on MRSA precautions if they've had it like within the past 2 years. Is there like a certain like life capacity for each of the different infections, or is like what's the?
It honestly
thought process
depends on the
behind that?
patient, how much MRSA they've had, how many antibiotics worked. There's a whole lot of factors that go into that. And what they're basically saying is everybody who's been down this road of having this infection, we're simply going to automatically do these precautions to try and prevent others from picking it up,
Yeah.
and to try and prevent basically that person from getting worse.
I'm just curious about like the 2 years, like why they picked that time frame.
Because typically if you're colonized with it now, you're doing something that's causing you to get it. You could have picked it up again when you went home. You could have picked it up after that antibiotic. You're more likely to have it. They simply picked a time.
Okay.
Part of it is statistically speaking, you're more likely to have it, but you can have it if you're 3 years out, you can have it in less than that too. And it really just depends on what you've got and how they're working. Most of the time, those precautions, the patient's already got it. So the precautions are to protect everybody else. So if you see something that's like, okay, look, we're recommending protective gear for everybody who goes into this particular room, it's more to protect everybody else that's there. It's not that the patient's already got it and they're treating that patient for it. If the patient is immunocompromised and they don't want you to deliver something to them, that's a whole nother issue. It just depends on what you've got. My grandmother was like that. She had MRSA, she was positive. This was April of last year. And it was like, okay, everybody's got to gown up.
Yeah.
Well,
'Cause a lot of
we
people-
brought in hospice, it was the end. And I was like, the nurse yelled at me. She's like, you're not wearing your protective gear. Screw you, she's dying, she's sitting in this bed, this is not much longer. I'm not putting on the darn gown. I want to hold her hand, and that's what we're doing because I'm not immune compromised. Like, my kids aren't here, so that's another issue. The kids weren't here. We all knew, everybody that was in there understood the risk, and it was like, that's it, this is what we're doing. So it has to, you need to understand why they're doing that for the patient or for everybody else who's visiting.
A lot of people
Yeah.
like, carry it but don't react.
Lots of people carry it. Lots of people carry it, and it's not causing you any problems whatsoever. Yeah.
Unless we-
Right. So all of those were antibiotics. Has anybody taken an antiviral? You have for flu, for some. See, in the event you get to a doctor early, antivirals can be an option for you. Most people who end up on antivirals, they're not going to do a lick of good because you take them too late. Okay, so the way an antiviral works is this is not going to do anything to destroy the virus, okay, itself. Once you get that infection is in your body. Remember, these are infectious agents. They're not living, dividing cells. So how these antivirals work, they're targeting some part of the virus life cycle. Remember, the virus is inside of the host cell. We don't want to just kill the host cells because we're killing cells in your body to try and kill the virus. So that's not going to work. So an antiviral is going to target some part of the virus life cycle. Typically, it's either the entry step, uncoating, the synthesis of new nucleic acids, or its assembly and release. There are lots of these against specific viruses. Think HIV. Okay, a lot of these are against HIV. The other one that we get these against that's common is going to be herpes viruses. Okay, we do have some of these against flu. The whole point of this is that you've got it. The timing of this has to be just right. You know, if what you are is HIV positive, then they're going to put you on a whole bunch of antivirals automatically. If you end up with herpes, herpes is one of those that you're just going to be on the antivirals, and that's going to keep that infection in check. If you're trying to take it for something that's more acute, in other words, it comes up, you deal with it for a short period of time, and then it goes away, something like the flu. The antivirals are only going to be effective if you take it early on in the infection. Most people have had flu for way too long for those antivirals to be effective. Sometimes they will give you antivirals as a prophylactic. So someone in your home was diagnosed with flu, we're giving everybody else the antivirals to try and prevent them from getting sick. Okay? You are not memorizing the drugs in the table. Don't worry about it. Okay? The point of this is to help you see that there are not a ton of these in the grand scheme of things. And the bottom line is most of these are used to treat infections that are life-threatening and that are not going away. Basically think HIV and herpes is the other one. Okay? So a lot of these, you have different targets. If you are, for example, HIV positive, they're going to put you on multiple antivirals. They're going to put you on antivirals that are targeting multiple steps because they're trying to avoid resistance and other things that happens with that. Okay, so there is a difference between being given an antibiotic and being given an antiviral. If you are having any sort of infection with a virus, the antiviral is the way to go. If your infection is with a bacterium, the antibiotic is the way to go. If they don't know what's causing your infection, they're typically giving you an antibiotic. So the example I want to give here is going to be pink eye, ear infections, sinus infections. Those are the top 3 where those causes can be either or. And we're not sampling what's in your sinuses, okay? You do not want them to stick a swab that far up there, okay? Bronchitis can, but we have easier ways of determining what's causing that. Ear infections are behind the eardrum, so there's no way to sample. Eye infections, you want to get that under control. Most of those are going to run its course and go away. So about 1/3 of the ear infections, eye infections, and sinus infections have a viral etiology. There's no way of knowing one way or the other, so you're kind of taking a gamble there. I can take the antibiotics. If it's caused by a virus, the virus is going to run its course, the infection is going to go away on its own anyway. So it's kind of a toss-up as to whether or not you take it or you don't take it. I would say if you've got pink eye, get the drops, take the drops, okay? If you've got an ear infections are those that are more common in kids and less in adults, but give them the antibiotics because the consequence could be their eardrum ruptures. The more rupturing you have to the eardrum, then you're worried about hearing loss. So you've got to weigh kind of pros and cons. Okay, I don't really want to take the antibiotic if this infection is going to go away on its own. But if my eardrum ruptures and the more this happens to me, permanent hearing loss and there's nothing we can do for this kid is a serious issue. Take the antibiotics. Okay, so it's all about kind of understanding what am I taking, what is the need, why would I do that, and understanding that infection.
So there's a question.
Yeah.
Homework.
Question from the homework. Let's hear it.
Antiviral drugs are capable of quickly inactivating viruses. Since latent viruses are not actively dividing,
Right.
Would that mean that antiviral drugs are capable of completely inactivating like active viruses?
What question
Does it say active? Okay, so the question says,
Which question number is it?
Question 9, I'm sorry.
question 9, so it says, it's a true or false, antiviral drugs are capable of completely inactivating viruses, okay? And yes, so remember, the virus is not a living cell, okay? It is simply an infectious particle. So it's not live. Any virus that's gone latent, those antivirals are not going to do a darn thing for. You can have viral infections that include some virus particles that have went latent and some virus particles that are actively working. It's not going to do anything for those latent particles. So from that standpoint, right alone, it's false.
Okay.
The other thing is that if you're targeting the entry step, you have cells that have the virus already in there and it's already going to be reproducing. Blocking this step isn't going to do those cells any good. So for cells that already carry that infection, already carry that virus, blocking the entry isn't going to work. If you have cells that are at this stage and you're blocking this stage, that's not going to do any good. It's going to keep producing. So
there's nothing we can
there's
do for a
nothing we
latent
can
infection.
do for a latent infection. And even if you're taking the antivirals, you are always going to have some infected host cells that are at a different stage of replication that are not going to be affected. So it's going to help, but it's not going to kill, it's not going to inactivate even actively replicating, and it's not going to affect anything that's latent either. Everybody got that one?
For the
Question number 9 is false. Question number 9.
For the influenza
Thank
antiviral,
you.
Yeah.
does it cover like all the strains? Like how does that?
The flu shot?
Like the antiviral, because like right,
So,
there can be a bunch of different strains.
There are different strains. Because so the question was, if you take these antivirals for the flu, are they going to work or not going to work? These targets are generic enough. They should be for every virus. It should be targeting it and it should be getting rid of it. The question is more of an issue of timing in that scenario. Yeah.
So even if you already have the virus and you're taking antiviral, it won't weaken it at all?
It might, but depending on how rampant this is, it might not do any good. And it really just depends. A lot of times for kids, they will give them the antivirals no matter what. if you are immune compromised and you get diagnosed, they will be giving you the antivirals no matter what, just to try and see if there's any way of slowing that down. For an adult who's got no other complicating factors, typically they're going to just tell you to ride it out. Yeah.
So how is it different than a vaccine then? Like, is it like, do you know what I mean?
Right. So the vaccine has got to be given before you get it, and the vaccine is causing your body to make antibodies which target all the virus particles and eliminate them.
Okay.
Yeah.
That's usually where they ask if you're sick before they give it to you.
Right. We went through this. We were on to antifungals, okay? In the event you get a fungal infection, understand you can't just take a basic antibiotic, okay? Antibiotics are against bacteria. Antivirals are against viruses. Antifungals are against a fungal infection. A fungus is a eukaryote. Your cells are eukaryotes, okay? They're not fungus. Your cells are eukaryotes. There are very few targets that are specific for the fungus that are not going to cause your body to have any issues. Most of these antifungals are going to have side effects because there is going to be some level of targeting of your cells that is going to happen. So most of these are given in a very diluted form, a very low dose to try and target that infection. The main target that these are commonly against that you could be taking is going to be ergosterol. So back to our cell structure stuff. We talked about how there are sterols in the membrane that are important for strength, and how our cells actually have cholesterol in that membrane that helps provide our cells some strength and helps keep them really nice and fluid. Okay, the older you get, the more you lose your sterols, which is where it's leading to wrinkles and all kinds of other stuff. Okay, fungal cells, their sterol is called ergosterol, and it's specific for the fungal cells. So we commonly are going to see targets against those. There are a few other targets as well, but those, they're not given very frequently. Okay. Most of these are an extensive protocol, and most of these could never work. So for example, you can search, there's a commercial that's against toenail fungus, for
Julia.
antifungal against, yes, okay? It's like 6 months, and they may never actually wipe out your toenail fungus, okay? Because of the fact that the drug is kind of diluted down, and the targets are just not that great. Okay, so understand if you get a fungal infection, that's a much more complicated process of getting rid of.
That's how it is.
Sweet.
Please remember, anytime you are taking an antibiotic, antimicrobial, it's going to alter your normal flora. Bottom line. Remember, the normal flora are good for you. You want them there. Yes, a small number of those are always going to be potential pathogens. But you've got to kind of weigh your pros and cons. What am I taking? What am I taking it for? Do I need to be taking this? Do I not need to be taking it? Is it broad spectrum? Is it narrow spectrum? There's a lot of things that go into, do you take a particular antimicrobial, yes or no? And what is that doing to your body? Understand you are always going to be destroying some level of beneficial species, and that's where you start to think of, how do I build up those good normal flora when I'm off that antibiotic? If your antimicrobial treatment fails, the first thing the physician is going to say is, it's your fault. You didn't take the drug right, you didn't take it when you were supposed to, did you take all the pills? They're never going to say it was my fault. They're going to say it was your fault. You want to be able to say, I took that drug absolutely as prescribed, so there is some other issue here. And that issue could be that the drug didn't get into the body compartment. That could be there was resistance. If they didn't do a susceptibility test, they may never have found it to start with. They could have done the test and that resistance didn't appear. Okay? Resistance can build up over time. Resistance can be spontaneous. Right? You could have an infection that's caused by more than one pathogen. That is completely possible. So the antibiotic wipes out one pathogen, but you've got more than one that's causing your infection. There's a lot that goes into this. This is kind of similar to that microbial control in that there's never one right answer for anything. Okay? We doing okay?